Good evening, everybody. My name is Anil Adikula. I am an orthodontist located in Denver, Colorado. I want to thank everybody for taking time out of a potentially busy weeknight for each and every one of you to hang out and learn a little bit. My goal of tonight's presentation is to help everybody make some smarter decisions in using Invisalign specifically. I'm going to tell you a little bit about our journey as a practice. I'm not going to spend a lot of time on the introductions because I want you to get the most out of this next hour. Please feel free to ask questions along the way. There will be a Q&A at the very end. And as questions come along, I might answer a couple as long as they're pertinent to the subject and as long as it's going to allow me to get through the slides because we've got a lot of meat and potatoes tonight, so I hope everyone is hungry. Tonight's webinar is called the Invisalign Efficiency Playbook, but this is just the first chapter. So chapter 1 is entitled Curing Attachment Disorder. The first main slide of all my presentations is always dedicated to my team. Like many offices say, the doctor cannot generate as much success as he or she has had over the years without their team, and this couldn't be more true without my team. Any success that we have is not due to me, but it's due to all of us as a unit. People are not replaceable in my office, even though people come and go and people move on to bigger and better things, but this is the one slide where I really get to thank my team for their undying commitment to me and their undying commitment to help change the profession. So back in 2008, I opened up my first office in South Denver, specifically the suburb of Lone Tree. This is a picture taken of my flagship office in Lone Tree in the Park Meadows area, and that was the night of our office opening party. The office looks exactly the same today, and things have progressed over time. Our goal was to set up in Colorado as a different type of office, and a lot of people try to set up that way, and I commend all of you for doing that and all of your successes for doing that. But our goal was to set up some kind of niche and some kind of different type of office and different experience for the patient. So that might just be my mind as a specialist, being an orthodontist, where you just focus on one thing and what you know, but we're going to talk a little bit more about that and how that played into my role into using Invisalign in my practice today. Every once in a while, you're going to see a slide of a beautiful smile and a beautiful patient in Colorado. This is my wonderful patient, Hannah, and this is just a nice little break to show you what outside can look like as we're inside for a webinar. But this is Hannah out by the Red Rocks area in Colorado. So we're going to talk a little bit about clinical excellence today. We've got some important pearls to cover, and a couple role models of mine. One is actually Henry Ford, of all people. So as I said, when we set up our office, we wanted to truly do something different. Henry Ford has an amazing quote, and he said, "If I asked people what they wanted, they would have asked for faster horses." So this similar mindset is also seen, or was seen, with Steve Jobs, where Steve Jobs said, a lot of times people don't know what they want until you show it to them. So we hang on to these quotes by these legends in our practice, in our treatment plan presentations, and most importantly, like I said, how we set up our office, because we wanted to actually show people the type of office that they would want instead of polling people and then responding or being reactive. So our entire office design and our entire office systems were completely different from the start, and it's ever evolving to try and set the pace in different aspects of orthodontics. So when I set up my practice, I decided, what can I do that's going to be different here in Colorado than every other orthodontic office, because it's very condensed, it's very competitive here in Denver, and you pretty much can drive by 5 or 10 orthodontic offices within 2 or 3 miles. So that might be very similar in your own area, but we needed to find a way to distinguish ourselves from other practices. So there was one of my mentors up in Canada, and he decided to treat every patient, regardless of age, with upper clear braces and lower clear braces regardless. He established an incredible niche in his area of town and is known worldwide as a completely aesthetic practice, and one of the first doctors ever that actually set up a completely aesthetic practice. And this was quite intriguing to me. And we tried it, and it kind of worked. There were some missteps along the way. So then I started to research what other orthodontists were doing here in Colorado. So what I did was I tried to see if there were any differences that we could take advantage of. And we realized that a lot of people were not doing lingual braces, which was very popular on the East Coast where I trained. So I'm from Philadelphia, born and raised, and I was blessed to attend the University of Pennsylvania for my residency and return home for those 2 years. And lingual braces and aesthetic orthodontics is very, very important, especially on the East Coast and in other metropolitan areas. But it really didn't seem like it was that important in Denver because orthodontists weren't doing it. But then we decided we were going to show patients what they wanted because they didn't really know. So we started doing a ton of lingual braces, and we started advertising this treatment modality. And from there, we ended up within 6 months, ended up being the fastest growing lingual braces office or lingual orthodontics office in the entire country. So we realized that there was a definite opening for aesthetic orthodontics in Denver just based on that. What we didn't realize is the headaches that went along with lingual braces, because in residency we did one case of lingual braces, and it's a little difficult when patients are paying upwards of $10,000 for lingual braces to have braces pop off and treatment be extended. So we decided to move on to a different type of treatment modality, and all of you know this as Invisalign. Now, there were not a lot of big Invisalign providers in Colorado when I first came here, but there was a fair amount. So we decided to embrace this, and I decided to try to attend every single CE class for Invisalign known to man, attending the summits and also using their online portals and watching a ton of webinars like you are today to try and learn as much as I could, because even though it is orthodontics, it's a completely different way to move teeth. The very first Invisalign case I ever did was in private practice. This was not allowed in our residency. So we embraced it, we moved forward, and in a matter of 4.5 years since our first case, and I mean this in all humility, we have been blessed enough to be the largest Invisalign provider in the state and almost the largest Invisalign provider in the Rocky Mountain region. And we were the only doctor and only office selected to educate our entire region at their first ever regional summit meeting last year. So we are humbled by this, we are blessed by this, and we are continuing to try and push forward to learn as much as we can about this, because there are tons of patients that are asking for this. And there are going to be tons of patients in your practice that are probably asking for this, or they don't know that they truly want this, so you need to show them that they want this. More beautiful patients outside. So in order to give some kind of credibility, yes, we might be the biggest provider in Colorado. Yes, we might be one of the biggest providers in the Rocky Mountain region and a lecturer and on a line speaker panel, but that's all hubbub. I got to show you some cases because I want to earn your trust, and I've got still so much to learn, so please, when I give you my contact information, please send me any suggestions or anything I want to learn. But let's go through some cases to show you what you can do with the Invisalign system. So I've categorized these based on the amount of time these patients were in treatment. Okay? And these are going to be initial records to progress records. I didn't do any initials to finals because I want to show you how quickly Invisalign can move teeth with the right treatment modalities programmed into it from the beginning. So a lot of it is your ClinCheck for sure, and educating the tech and getting the teeth to move the way you want them to before the trays are fabricated. But we're going to talk about some clinical aspects of Invisalign, not necessarily the ClinCheck, but the materials you're using that will further enhance your efficiency in this treatment. Because you really do not have emergencies with Invisalign whatsoever. If a patient loses a tray, they most likely can go to their next tray. But if a patient loses something like an attachment, that is where, if that attachment is truly needed for ideal tooth movement, you're going to need to see them in, and that is the closest thing Invisalign to a broken bracket. So the more that you can minimize this somewhat minor emergency, the quicker you can finish patients, the quicker you can deliver on your promises, the greater your efficiency is, the greater your profitability is, the greater your reputation is, and the more patients you will be able to see as a whole. So, in 4 months of treatment, we can take a patient like this, where they have a crossbite, okay? Minor crossbite, nothing too severe, some minimal lower crowding, and you can fully correct a crossbite. So that is in 4 months of treatment, okay? Now, we still have some open bite areas. Once again, these are refinement photos. So right now, we are scanning these patients' teeth again to get some more trays to finish up their treatment. In 5 months of treatment, you can see patients that you're going to see every day with lower anterior crowding, upper anterior crowding, and some narrow arches, straightening out beautifully, although still not ideal. We're still working on them, but patients are thrilled in minimal time. You'll see here, here's a Class 2 canine, Class 2 end-on canine, Class 2 molar. Patients can be very compliant wearing elastics. When patients are wearing elastics from lower Invisalign trays to upper Invisalign trays, in my office, attachments are a must to retain the top tray when they're wearing Class 2 elastics. And you can see in just a minimal amount of time, and I'm going to go back again, okay? So we're going from here, focus on this picture right here on the bottom left. We're going to a Class 2 end-on canine to here in a minimal amount of time. We've gotten so much Class 1 correction, even though we're not fully corrected yet, that we actually created a diastema between the upper front teeth. Moving on. 6 months of treatment. So we have some patients that have a Class 2 Div 2 appearance of the upper incisors, even though they are Class 1. They have a fairly moderate amount of lower anterior crowding. So once again, in 6 months of treatment, you can see how nicely things can align. Okay? Friends notice a difference, patients notice a difference. When you're talking about not just aesthetic treatment in Invisalign, speed of treatment and efficiency is very, very important. Okay? Patients think that when they're switching out a tray every week or every 2 weeks, they should be seeing a change every week or every 2 weeks. But we know that doesn't happen. We tell patients that they will start seeing changes usually in about 6 weeks. Even though they might feel changes in week 1 or week 2, they'll start seeing changes in week 6. And that usually holds true. Friends usually only see changes in week 8 to week 10 at the earliest. And these are, now I'm only talking about anterior changes here in terms of whether or not it's visible. But you need to prepare your patients that when you see them back on a shorter recall or next Wednesday when they put in their trays again or whatever the recall is, they will not be seeing changes that dramatically. 7 months of treatment. So you will see a lot of times patients will have significant enough lower anterior crowding that you will need to extract a lower anterior tooth. Patients might not want braces for aesthetic reasons, especially young professional ladies. So you can see in just a minimal amount of time how we can extract an incisor, close up the space beautifully, and then what we're working on right here is we're working on tipping the root so that we eliminate this black triangle. We encourage papilla to fill up here. And once again, when you're tipping roots and you're doing extractions, you have got to use attachments, and your attachments have to stay on. If you do not have attachments, the teeth will only tip because you're pushing from the top and you don't have a rigid wire to translate that tooth or move the root effectively, and this space will open up and you will have a large black triangle. Patients will have straight teeth, but they will not be too happy with you. So we will also get into attachment design, I promise you. So we take x-rays before and after, that is the previous patient. You can see that right here, there is a little bit extra root distance compared to these two incisors, so that is what is going to indicate for us to put vertical attachments on these teeth and advise our tech to add some distal root torque to this tooth, potential mesial root tip to this tooth, and that will only enhance that gingival atmosphere there. So sometimes we have some teenagers who just do not want braces, and this was my first ever extraction case when we're talking about a premolar on any patient. And I did realize that our teenage patients have teeth that move faster. So I'm just going to tell you how things work in Colorado. I don't know how things are going to work in your state or your city, but Invisalign on teenagers works absolutely beautifully. Everyone is worried about whether or not teenagers will wear their trays. A lot of this has to do with psychological wording, and a lot of teenagers are irresponsible and will not wear those trays, but hopefully you find that out at the new patient consultation, and you can weed those patients out on whether or not they're actually qualified for that and a treatment modality for that. And most likely parents will tell you. So we use the parents as a gauge. We also have the parents and the child sign a contract with us that if treatment does not progress as planned, we will go into braces, because that is your only option. And I don't want to tell a patient that they're lying or accuse them or anything. So if it's not going as planned, for whatever reasons, we'll go ahead and go into braces. And 9 times out of 10 in a teenager, if it's not going as planned, it's due to compliance. So in this case, we decided to extract tooth number 5, or her upper right first premolar, and use elastics, use a big attachment on this canine because I just don't need to bring it back, but I need to bring it down. So a special angulation of an attachment was very, very big. We always bond buttons on the lower first molars, and we use class 2 elastics when we're closing spaces like this currently. We don't use the precision cuts on the molars. We prefer buttons. I want something quite firm, and sometimes in patients we will use bands. So you can see quite quickly how she corrects to a class 1 canine before our eyes, and I was shocked at how quickly this worked. Another diastema in the front, beautiful class 1 on the left side. So finishing a case like this in Invisalign is a piece of cake. More beautiful sisters that were patients of ours in Colorado. So one of the things we also realized about Invisalign that we thought would happen with lingual braces was the marketing that patients do for you. When people get lingual braces, and it was going so well and it was growing, patients were coming to us not necessarily because patients would say, you got to go to Dr. I and the Dream Team. You got to go see them because I love my lingual braces. Patients get lingual braces because they want to hide them. Invisalign is also a chosen treatment modality because patients want to hide them, but unfortunately when you're taking trays in and out, when you're eating or when you're socializing and things like that, it inevitably becomes a topic of conversation, in addition to the fact that Invisalign is more visible than lingual braces. So therefore, it becomes a topic of conversation whether or not the patient wants that to be true. The most powerful marketing tool when it comes to Invisalign, and after you start doing more Invisalign cases, as many doctors can attest to, is your website, and when on the Invisalign Doctor Finder, they start dropping these little tiny dots on maps wherever your office is. So just like a dam full of patients, holding back patients. If you start dropping these pins and start setting up offices like we did, now that we have 4 locations, you drop these pins and all of a sudden these patients start finding you from all over. It is unbelievable, this website and how the marketing that they draw patients. So if you start doing a lot of Invisalign, news alert, you got to get good at it, because no matter whether or not you like it or approve it as a treatment modality, patients will be coming. They will find you based on status on the doctor locator. They will be flocking to you left and right. One of the key things on this doctor locator is you have this unique website that you can write down or submit to Invisalign for them to direct patients that are finding you online already to find your website. This is an old version of what we used to have in our old website, which was livelifesmiling.com, which is our tagline, and we would just direct it to the patient would then click on this, go to our website, and it would be a standard welcome page. Welcome to our office, and then obviously they would want to scroll and find out where our office is, or they would want to try to figure out, okay, so where's the Invisalign stuff on their page? We've since changed this to a unique URL that goes to this. And the wording is very specific, so please take note of this. We say congratulations on choosing the top provider for accelerated Invisalign, and we'll talk about what accelerated Invisalign is. So congratulations on choosing the top provider for accelerated Invisalign treatments in the world. Dr. I and his dream team are excited to get started on helping you achieve your smile. So we are further qualifying those patients that are coming to our website and directing them to that. More patients. Okay, so when we're talking to our techs at Invisalign, we have to start out with baby food. Please don't send them a list of 30 things for them to do on that first clin check. This is exactly how I write things down. I address my tech by their first name. Psychological principle, everyone likes hearing their first name. So please, use people's first name, use patient's first name as often as possible so it doesn't look like you're crazy. Okay? So we know our techs by first name. We have a tech assigned to us. So at this time it was John. And I have 3 categories: attachments, IPR, and elastics. And that's all the baby food I give to John. Attachments, all 3s please. Okay? So I want them on all the canines. IPR, none. Elastics, none. Thanks, a nil. That's all that John needs to know. There will be some discussion back and forth, and you always set up your clinical preferences. I will show you my clinical preferences. I've got nothing to hide. I am here for you to learn as much as possible. I will show you every clinical preference I put in. But let's get to the attachments. And why are attachments so important in Invisalign? Once again, because this is the only potential emergency you will have. So the more predictable you get your attachments on, the better your treatment will be, along with attachment design and, of course, your clin check. Here's an example. When we switched to Daniel, okay, I asked for no IPR, no elastics, attachments all around, okay, as big as possible, because I like attachments to be big. Okay, I want as much surface area for my aligners to grip these attachments and move the teeth that actually need attachments. Invisalign has what's called optimized attachments. They're small, they're cute, they're in the shape of a comma or a teardrop. They have all this engineering that goes into it. Fantastic, okay? What I know is the big attachments work, so there's no reason for me to sway away from something like this. And obviously, as you've seen, treatment goes quite efficient and fast. So I stick with the big attachments. The other problem with these these optimized attachments, the smaller ones, is they look funny. They look like little tiny pearls on people's teeth. I don't like that. The big attachments you can hide a little better, even though, believe it or not, they're bigger. They look more uniform. We always make attachments symmetrical. So if there's a vertical attachment on tooth number 6 or the upper right canine, I put one on tooth number 11 or the upper left canine, regardless of whether or not they need it, because symmetry is exactly what they want. So let's keep jamming. We isolate. We get the patients isolated. This is an example of what this piece looks like. Now, if these attachments come off, obviously one of the biggest reasons for attachments to come off is what are you using to get the composite to bond to the teeth. We don't need to have a webinar on etch. Etch is etch, okay? Use what you're doing. But a lot of times with Invisalign, one of the key factors is people will need attachments on certain teeth, but doctors change where the attachments are because a patient has a crown, because they don't want to bond an attachment onto a crown, because clearly attachments don't secure well to crowns. That's a fact. Just like people don't like to put braces on crowns, we prefer to actually put bands on crowns. We exclusively use Futurabond U because you don't need any silane, because it will bond to every material in the mouth, and you could put an attachment on any tooth that you want. It's a true universal capabilities, so you don't have to think, even though I need an attachment on a molar or on a premolar because it has a crown, I cannot do it. Okay? No primer or activator is needed, and the adhesion is through the roof. This is what it looks like. We use single dose. Okay? Here are the instructions. Okay? After washing off the tooth and washing off the surface, and this is an example for a restoration prep. Drying off the tooth, you go ahead and you pinch the blue area, okay, into the gray well. You mix that. You apply this for 20 seconds. Okay, so it's a little bit of a longer application, but I would much rather spend more time applying this, knowing it's going to stay in there, than repairing it, because nothing's going to take longer than a repair. Air dry for 5 seconds, cure for 10 seconds. Okay? So, spend the time up front, just like you spend the time on your ClinChecks, to make your life during your treatment days easier. So once again, no more need for multiple bonding agents, zirconia, metal primer, silane, anything. This is the key to happiness. Okay? When I was looking for what to use material-wise, I would talk to doctors because I needed to find out what they were using. Okay? What are you using? What do I need to use? Then I decided to do my research on my own, stumbled across this product, and it has been incredible. Okay, now, attachment material. A lot of orthodontists decide to use bracket adhesive for attachment material. It totally makes sense based on inventory. It's sitting right there at every chair. Assistants know how to use it, so you don't need to order this extra inventory. It's clear. I mean, everything sounds perfect until what happens is over the course of 6 months or 8 months of treatment, and patients have these attachments on, you will notice the attachments start to flake off. Or, more importantly, attachments start to wear down and you can't even fully tell. Any Invisalign speaker that discusses attachments, and Invisalign will tell you themselves, the surface of the attachment, aka the working surface, that the aligner is pushing on when it's activated, should never be touched when you're cleaning off flash, or during treatment. If there is any damage there, Invisalign will recommend that you repair that. That is all you have to push on. It's much like if a bracket breaks in half. You are going to replace it because you cannot get the proper force distribution on that tooth. Therefore, you cannot use any bracket adhesive on the market today. It is not filled enough to be resistant. Okay? You will get less predictable tooth movement, I guarantee you. So, we have products such as Grandio, okay, which comes in a packable form just like this, and you have what we use is Grandioso, which is a heavy flow. Some orthodontists decide to use flowable composite if they're doing indirect bonding like we are in our office universally. The beauty of flowable composite, as you all know, is its delivery into the attachment wells. When I design attachments with Invisalign, I want my attachments to be placed in the junction of the incisal and middle thirds of the tooth. And that is just something that I've learned and something that I swear by today, because the aligner is more rigid there, which means it's going to grip the attachment better. Unfortunately, if you put attachments at the junction of the incisal and middle third, of the actual tray, the attachment wells, what happens is it's difficult to get any attachment material into those attachment wells or attachment trays when you have to load the tray before you place it in the patient's mouth. So you're going to need some kind of delivery system that's going to be predictable or less clumsy, especially if you have assistants loading them before you cure them. Grandioso has been the solution for us because it has these beautiful tips, but more importantly, I'm going to show you the exact one that I use, and it is this one. It's these. So it's the same capsule method, but it has the extended tip here. So you can easily place this into any attachment well on any attachment template and get a perfect fill without any flash or any mess in the loading. There are different colors to choose from, which is fine and dandy. And so if you're the type of office that wants to choose different colors to match different shades and you're going to shade match, I commend you. Unfortunately, due to the systems in our office and based on the patient response, everyone gets A1 in our office right now. It is just to have inventory. It's to keep things more efficient in our office, and we can move faster with patients that way, and we haven't had a single complaint yet. You can see how beautiful these attachments look when they come on. They are almost unnoticeable. This is a typical setup by our chair. For those of you that have orthodontic offices, we actually have a Velo light by Opal or Ultradent that we use right there. There's many different variations. This is just what we use currently in our downtown office, which is probably about 99% Invisalign patients. Let's talk a little bit about polishing teeth, okay? Invisalign is amazing at closing spaces. Invisalign is not amazing at closing spaces fully. So, therefore, we try to think or outthink Invisalign. Here's another thing. John, no elastics. IPR, lower left and right posterior teeth, 0.8 millimeter increments, all before tray 3. Attachments upper 3, 5, 6, blah, blah, blah. Focus on the IPR here, okay? 0.8 millimeters is enough IPR to drive a truck through. Once again, Invisalign is really good at closing spaces. It's just not good at closing spaces fully. So, if I ask John to program 0.8 millimeters of space between two lower incisors, and Invisalign's really good at closing spaces but not really good at closing spaces fully, there will almost always be residual space left after that round of Invisalign. And we do not use this virtual chain only because of how we program trays, which I will get into. And there's a valid reason why for us, and it's about systems and efficiency. So I always ask for 0.8 millimeters, but I never do or perform on the patient more than 0.4. So what that allows for me is it allows Invisalign to close that 0.4 space really, really well and not close that 0.8 space fully, and aka, therefore, it will close the space and we will eliminate residual space. This is our protocol. We use finishing strips and we use these Neo Diamonds. They're super, super microfine and they work fantastic for IPR. We do not use the rotating discs. I don't sit there and try and sand exactly to the same amount every single time. I always ask for more IPR than I'm going to do, because to sit there and take an IPR gauge and measure 0.2 millimeters on this tooth, 0.4 millimeters on this tooth, 0.8 millimeters on that tooth, I hope you have about an hour for that patient. So a lot of this has to do with efficiency, and we know that we're not doing any more harm to a patient by any means by doing 0.2 millimeters versus 0.4 millimeters of IPR. And plenty of studies show that IPR causes more stability of teeth, especially if you're using a keystoning technique, which we can get into at a future webinar. So we're only enhancing the stability of patients, but we do not do IPR unless it is absolutely necessary. I hope everyone's having fun, by the way. Okay, so now we're moving on from baby food, and let's get to a little more meat and potatoes, because now we're going to keep dancing with our tech and keep chatting back and forth. So meat and potatoes of Invisalign is I ask at appointment 1 for our patients, this is what we do. We give patients trays 1 and 2. We go over chewies, which are crucial to Invisalign success. You have to make sure patients are not just pushing up on trays or pushing down on trays to seat them. We all know that nothing's stronger than the muscles of mastication, so we give them these chewies to have them bite down. And the other thing we do, here's another marketing pearl, is we email them their ClinCheck and their video so that they can open this up at work or at home and look at this video of how their teeth can virtually result in. This is not, there's specific wording in this. Please feel free to email me at the end. I will send you the exact template of the email that we send to patients, and we tell them congratulations. Once again, patients love to hear their name. Patients love to be complimented, so we congratulate them on their choice on choosing us. And we show them what their teeth can look like. These are what chewies look like. We have patients bite down on these things for 5 minutes every night. Now, once again, I ask my mentors and they say chewies, chewies, chewies. But me being the rebel that I am, and I always have been, we try to find a better way. Not that the chewies don't work great, but let's go back to inventory and let's look at cost. These beautiful slow-speed suction tips that cost roughly 2 cents per tip are sitting in everyone's office. These work amazing as chewies. They're bendable so they can fit in the case. They have a beautiful long handle that patients can hold on to. Yes, they might recognize it as a suction tip. It doesn't matter. The bottom line is this works amazing. And I have no problem giving a patient 10, 20 of these as needed because my cost is still less than one chewy. Patients will get addicted to chewies or these because you are telling them that this is the key to their success. So, at the least in this webinar, hopefully I've saved you each at least $100,000 in chewies. More beautiful patients. Clinical preferences. These are all my clinical preferences. Please move all teeth at all times unless they are passive trays. Okay? Invisalign is going to make the fewest trays possible based on the most crooked tooth. It makes sense from a business point of view. If I'm the Invisalign CEO, I do not want to make a lot of trays because it's costing me a lot of money. I want the fewest trays possible so that it's going to cost my warehouse the least amount possible. So, therefore, the most crooked tooth, if it's going to take 21 trays for me to straighten that crooked tooth, I'm only going to give you 21 trays in this ClinCheck. So, what we do is just because another tooth only takes 5 trays to straighten, I am going to spread out that treatment over 21 trays, even though it's tiny, tiny, tiny movements. Because I know that Invisalign can still not straighten teeth in my hands to the ultimate ability after the first round. So we move all teeth at all times. We start and finish both arches at the same time. I do not start both at the same time and all of a sudden you're done with your lower treatment 4 months into treatment, and then 8 months later you're done with your upper. Okay, that is sloppy and it has to do with patient management. We start and finish both at the same time. You want to make these systems dummy-proof and efficient. We perform all of our IPR whenever we can. We add all our attachments whenever we can, and we start our rubber bands immediately before tray 3. This is very, very important. There's a psychological reason for this. We give patients 2 trays at their first appointment when they get Invisalign. The reason we give them 2 trays is because we want them to get into the routine or get in their agenda that they have to switch out trays every week or every 2 weeks, depending on how often you switch out their trays. So this is a good template for them to know when to switch out their trays. The other thing is I don't want to throw on a bunch of attachments on teeth, even though I know I need them to be clinically excellent with Invisalign still today, and have them struggle for an hour in my office on how to get these trays off. The trays are hard enough to get off without attachments for a new Invisalign patient. So this eases them into things. They realize they need to switch them out every week or 2 weeks, and then we add attachments. And we add all attachments then, because I don't want multiple attachment appointments in my office or in a patient's treatment. The only time we have to switch out attachments or put attachments on at different times is when there might be a crossbite or an occlusal or incisal interference. I try to perform all IPR at that same appointment, and we start rubber bands right away. So we have this one fairly long appointment where we educate patients and everything, but I want to throw the kitchen sink to them at this appointment, but not the first appointment. And I don't want to bring patients in every 2 weeks or every 4 weeks because the ClinCheck says I need to add another attachment. So this is a very important clinical preference that we add. Now, if a patient goes into a refinement, which I will tell you right now, I'm not one of the Invisalign lecturers that likes to brag about a low refinement amount. Okay? We will not settle for anything but perfection, and we tell patients you're not investing in Invisalign with our office because they can invest in Invisalign at any office. You're investing in a perfect smile. So this might take multiple rounds from our office, but it's only because we do not want to settle for anything but perfection for you. Now, if you phrase that to them in a consultation, you don't have to get bummed out when you have to do a refinement. You actually have to get excited, where you have to say, wow, you come a really long way, Johnny, Julie, whatever your patient is, but I really want to make sure this is perfect for you. What we're going to do is we are going to take off your attachments, take molds of your teeth or scan your teeth depending on what technology you have in your office, and we're going to get some brand new trays for you to get things to be perfect, and we will not give up. That, to me, is a win. So, if it's a refinement, though, and they're in their second round of trays, there's no need for me to give them 2 trays for them to get used to taking out trays or what attachments are going to be like because they're used to it. So we will do all of those appointments, all of those procedures before tray 1. So right when they come in for their first tray of their refinement, attachments go on, elastics, IPR, whatever needs to be done. When you're extruding teeth, we want visible space. That is very important. You need to be friction-free with Invisalign. We will never extrude a tooth before placing an attachment because, quite obviously, Invisalign cannot grip a tooth and extrude it. It only has plastic and it's holding slippery sides of teeth. So, on trays 1 and 2, since there are no attachments, we never do extrusions. Please place all non-optimized attachments. Remember, we do not use optimized attachments in our office. We use non-optimized attachments so that they are bigger, and we place them at the junction of the lower and middle thirds of the tooth. And by lower, I mean incisal or occlusal and middle thirds of the tooth. And one of the biggest efficiencies you can build into your Invisalign patients is by keeping the last 3 of aligners passive. And we need to discuss why in just a bit. We also want to remove all attachments before those last 3 passive aligners. I know that sounds very odd. And we want to keep those last 3 passive aligners free of those attachment wells. Because sometimes Invisalign doesn't know that just because you remove an attachment, that they have to remove those attachment bumps or those wells in their trays. Now, if we have the last 3 sets of aligners passive, that means that right before we do that, at the appointment where we remove all the attachments and before we give them their last sets of passive aligners, those 3, a patient has 2 options based on your treatment recommendations. They are either done with treatment because you've gotten into the end zone, things look amazing, or they're going into refinement. If they're done with treatment, the patient's going to need retainers. And you have just gotten yourself 3 sets of Invisalign retainers for free. You've taken off the attachments, and you got 3 sets of beautiful Invisalign aligners without any attachment wells, and they're obviously going to fit because the patient is done with treatment. The other option, which is a win once again, is, I'm sorry, Johnny, teeth are not totally perfect, but the amazing thing is that we want to get to perfection. So, in our office, over 90% of our patients get at least 1 refinement. Okay? Over 40%, I would say, and I don't know the exact number, I'll have to look at that, I apologize. Over 40% get 2 refinements. Okay? There are speakers on the Invisalign circuit that have less than a 5% refinement rate. That is incredible. And those are the speakers and lectures that I end up going to because I would love to reduce this, but we can't settle for anything but perfection. So, once again, either way, with this specific clinical preference, you will win. When we're talking about pontics and closing spaces, you need to focus on the pontic size. You want the pontic to be smaller. I know it's not as aesthetic, but patients really don't know that well on If it's a little bit, half a millimeter smaller, you want full grip of those abutment teeth when you're closing extraction spaces. And you want to use what's called gable bend technology right here. That means they're going to move the root, and they're also going to move the crown. So it's going to be a little bit of a dance. Okay? Attachments are key for that. Staging. Staging is a very important button to hit with Invisalign, and this is an ideal staging that we see. Every tooth is moving. You can see every tooth here is moving. I love this. When you see choppiness here, that means they're not moving teeth at certain times. All attachments are going on right before tray 3. All attachments are coming off at the end of this last tray, and then here are my passive aligners. Now, are these truly passive? No, because Invisalign will say they don't like to make passive aligners, or they cannot. So what I asked them to do is I asked them to intrude this upper right 7 over the last 3 aligners, 0.1 millimeters. And I asked them to intrude the lower right 7, 0.1 millimeters. Now, people, are you going to intrude this 1.1 millimeters? No. This is the key. So it's not a passive aligner, but Invisalign will still make it. These are going to be either your retainers, or they're going to be holding the patient while they get the refinement trays, while you get them back from Invisalign. More beautiful patients. Now, I just want to give you a preview of some of the future chapters that we'll be discussing, okay? There's a lot of exciting things in the world of Invisalign, and the key is to make this efficient, because you can get bogged down by your schedule with this very easily, because it's a different treatment modality, and a lot of times, us as doctors, we are not dictating what needs to be done when, so that our assistants and we are not fumbling during those appointments. We need to make sure this fits our systems, and the more efficient you can make this, the happier patients are going to be, the happier staff are going to be, and the more time you can spend on the ClinChecks, which is exactly where the time needs to be spent for you to get predictable Invisalign movement and become the elite provider in your area. We're going to talk a little bit about scanning at some point and the power of that, both appointments and efficiencies, and how quickly ClinChecks can be turned around, the fits of trays. We discuss multiple scan sheets to keep your efficiencies on point if patients are being scanned when doctors are not there. We'll talk about what's called Accelerant. Accelerated orthodontics is probably the hottest topic today, along with these scanners. Accelerated orthodontics, everyone wants things faster, not just the orthodontists, but more importantly, the patients. So, this little unit here will allow your patients to change their trays every week or every 5 days. We have some doctors using this and changing their trays, having their patients change their trays every 3 days. It is absolutely incredible the rate of tooth movement and stability you get with this device called Accelerant. We'll talk about the type of appointments that you need. This is every single type of Invisalign appointment we have. This is not a lot. It is very regimented. You can ask any assistant of mine what the next appointment was going to be. They will know the code, and they will know the length, and they will know exactly how to schedule it. A very happy Invisalign patient. The last and final section that I have is, I hope everyone has learned something from this webinar. I know it's there's a lot that I was throwing at you, but there's a lot that I wanted to show you. What I really, I wouldn't be doing my service if I didn't tell you that the best way to thank me for this webinar, to thank whoever told you, is really to do your best to give back more to patients, because all these little tips are definitely going to increase your profitability, but I guarantee you the more you give, the more you get. So please, if anyone has any questions about philanthropy, because I'm always trying to learn this, but if anyone needs any help organizing fundraisers in their area, if anyone needs any help, on creative ways to partner with communities and community organizations, there are so many children in need in your backyard. Yes, definitely in third world countries, but definitely in your backyard. If there's any help or any motivation, please call me, because for me, this is what life is truly about. This is my contact information. Once again, my name is Anil. My patients call me Dr. I. You can call me Anil. You can call me whatever you want. But there's my email address. This is my personal cell number. Every patient of mine gets my personal cell number. We want patients to contact me directly. They can text me. They can call me, whatever they need. And I want to offer you the same. You can call me directly on my cell phone at any time. I will do my best to get back to you as soon as possible. I'm here for you. The best way to thank all of my mentors is to spread the word and try and teach and help other people not make the mistakes that I did. So I'm going to field some questions. So please feel free to submit as many questions as you want. I want to make sure I can answer as many questions as you guys have all submitted. So once again, thanks again. Please let me know whatever questions you might have. Somebody asked me, Lynn, thanks for asking me. You asked for Class 2 elastics, do you bond buttons or use cutouts in the tray? Once again, to clarify that, I appreciate that question. For Class 2 elastics, I will once again bond a button on the lower sixes or lower first molars, or I will band them depending on their occlusion and how brachyfacial they are. And I definitely use cutouts, and I use those cutouts mesial to the upper canines. Whenever I do elastics, once again, if I'm doing Class 3 elastics, I'll put attachments on the lower canines and sometimes the lower first premolars. If I'm doing Class 2 elastics, I'll do attachments on the upper canines and upper first premolars. Okay, you just need that retention there, so I'd rather build it in and have it there. And we express that to patients. And the way we express that to patients, so once again it's a win, is attachments and consultations should not be some hurdle you have to get over. You have to make this as this is their golden ticket. So we tell patients, Johnny, for example, Johnny, I got great news. We can totally do this with Invisalign. We can correct your teeth. We know exactly how to do this to avoid metal and braces. As long as I can put some attachments that blend in beautifully with your teeth, I put them on at the beginning of treatment. I take them on. You'll hardly even notice them. I can avoid all metal and wires on your teeth. So when we're talking about the psychology of wording, that is something that you want to research and use in your own special way to view what could be viewed as obstacles in some offices as wins in your office. Let's see, some more questions. Yvonne, you asked a great question. How do you feel about a general practitioner doing Invisalign versus a specialist? For me, it's all about training. I'm going to be blunt. Okay, I've heard some amazing lectures by general dentists and orthodontists doing Invisalign. For me, it's completely 100% about education. So there are many general dentists that are more educated than orthodontists on Invisalign, and I would rather go to them than a lesser educated orthodontist on that. Invisalign is a very special treatment modality. I think as a whole, orthodontists are definitely more qualified than general dentists, just based on our 2 years of schooling on tooth movement, tip, torque, things like that. But I can't give you a generalized feel. It's going to be very individualized based on that practitioner. Please stay tuned for future webinars. We will get those scheduled, and we will make sure that we get in touch with you about all of this. We will definitely talk about Excelident. We'll talk about other different appliances and modalities and Invisalign add-ons. There's so much when it comes to verbiage and pricing. There's a lot to learn. I encourage any of you, if you happen to be coming to the AAO or the PCSO or the SAO this year, I'd love to have you attend one of the lectures that I'll be giving. I'd love to introduce myself and meet you. It's the most humbling thing for me. I'm blessed by all of you. So if you're around, please let me know. When we do bands, by the way, and these Class 2 elastics, another great question. Cynthia asked, how are you using bands with aligners? So Cynthia, that's a great question. What we would do is, if we're actually going to be doing the bands, we modify that aligner slightly. So either if we determine we're going to be doing bands in the beginning, we put the bands on and we have Invisalign form the aligner over it, which is the ideal. If we're doing it after the fact, we'll fit the bands and we will just cut out the buccal area, but it will sit occlusally quite nicely and lingually, but we might have to trim lingually. The problem with doing it after the fact is you have to trim a lot of those trays. So try to plan that in the beginning as much as possible. Let's see, other questions. Dahlia, can you get you wanted to know if we get the presentation to study from? Absolutely. I have 0 secrets. Let's see, more questions. Yvonne asked a great question. What about traditional braces? What type do you use when you see Invisalign is not working? So to be honest, we can talk about that in future webinars. The type of braces is not the most important to me. It's the knowledge behind it, and we routinely will recommend hybrid cases. Patients are thrilled to do Invisalign for the first 12 to 16 months and then do braces for 6 months. I don't start with braces. I end with braces. Okay? So, and there's a pretty big difference there. I want patients to be happy from the start. I want them to be excited. I want to do the fine-tuning with braces as needed. So you can always do braces at the end or hybrids to fine-tune that, and do not be ashamed to say, you know, I have to do braces at the end. You can easily say, this is amazing. We can absolutely do this with Invisalign and braces. I'll need 6 months at the end to fine-tune everything because it's got to be perfect. How excited are you? Okay. Also, this webinar will be archived at www.vocalearning. That's VOCOLEARNING.com. So www.vocalearning.com by next week. So feel free to log on and see when that's going to be on there. Okay. Let's see. Just going to try and field some last-minute questions. Janet asked a great question. What do you think about the G5 features? Janet, the G5 and Invisalign is really nice. They're doing some really great stuff. To be honest, all of the previous features are working fantastic. So I'm going to be picking and choosing certain features that work better for me, and using them appropriately. But the ClinCheck 3D seems to be pretty amazing. And it's not just something showy. It's really nice to be able to control those teeth and actually move them directly without having to express this verbally to a tech. So that's going to have the most impact for sure on my patients and my patient care. Ryan asked if I etch with Futuribon U. Ryan, I'm sorry I didn't address that. I absolutely do etch. Okay, even though you don't have to, I do. I etch because, and I also do that with my brackets. So we do the Futuribon U, the self-etching, even though it is self-etching, and we also etch on our own. That's a really good question. Dahlia, once again, thanks for your comments. Everyone else, thank you so much. Any other questions? I'm gonna hang out for a little bit longer. I'm not going anywhere. Please let me know. I am here for you. Email me, call me, text me. All right, gang. Thanks again for attending. I really, really appreciate it. And I'm here for you 100%. So I really want to thank Voco and all the materials that we use. It's been huge for my practice, and I hope that this helps you in your practices even more. And I hope that you all have the opportunity to see some more patients and be able to give back more in your community. Have a great night, everybody.